and it will activate platelet. Platelet begin to release what?
ADP.
Thromboxane. Thromboxane. Who made thromboxane?
Prostaglandin. Arachidonic acid.
And
Yeah, cyclooxygenase pathway.
COX-1 make prostaglandins we don't take. We need only
Thromboxane A2.
Thromboxane A2 will act on the receptors. Yes. They bind with what? G protein.
GQ.
Q means that they stimulate what? Phospholipase C. You remember this information? It make from inositol D phosphate, inositol 3 phosphate, and it increase
Calcium.
And calcium will activate what glycoprotein?
2B3A.
2B3A. And it will bind with
Fibrin.
Fibrin again and another platelet. And we have aggregation. That's very good. But if we don't have problems without vessels, vessels will release something to prevent aggregation. What?
Prostacyclin.
Prostacyclin will bind with what? With receptor, which binds with what?
GS.
Activate adenylyl
Cyclic
and
Decrease.
calcium. So we will decrease calcium and prevent the aggregation. Okay, but if platelet is activated, it releases ADP, also ADP, which will bind with the receptor to AGP,
GI.
inhibit adenylate class, inhibit, and it will increase calcium.
Increase calcium.
Adenylate class decrease, yes, but if we will inhibit, it will increase and lead to aggregation. Then cyclic AMP may be destroyed by what
Phosphodiesterase.
Destroyed, yes. This information you know. It is aggregation, yes. To prevent aggregation, we need to do something to block this way, or to activate this way, yes, or to increase cyclic AMP. So we need
Inhibit phosphodiesterase.
The classification of anti-aggregants.
We have action on hemostasis and action on hemoptosis. The action on
Anti-aggregants which prevent aggregation. So the drugs which will affect on the platelet and on this. What we do?
We have three antiplatelets, antithrombin,
Anticoagulants and inhibitors.
antifibrinocytes.
So, first of all, we speak about aggregation. How to prevent aggregation? What we can do? We say that we need to block the effect of thromboxane eating.
We have COX-1, so we will use aspirin to inhibit the
COX-1. In what dose?
And it will affect on the arachidonic acid that will lead to decrease the formation of
aspirin. In what doses we need to
Low
use?
doses.
Low doses. You remember, yes? What side effect may be? Bleeding and ulceration. Yes, you remember this information. Okay. The second drug, what is it?
ADP receptor
Blocker. What's the names of the drugs?
There's
Diclofenac, yes, and clopidogrel. They have clop in the what, yes? Diclofenac and clopidogrel. Okay, what else we can do?
Third one is not blocker, it's glycoprotein.
Drugs which will block glycoprotein, yes? What is that? Yes, we can block this. Okay. Read all together. Apixaban, eptifibatide, and tirofiban. Matthew, repeat please. Apixaban, eptifibatide, and tirofiban. Again, please.
Abscisimal
MAB,
and
tirofiban, ban, eptifiban. What does it mean, MAB?
Monoclonal antibodies.
Antibody. If you have MAB at the end, it is antibody, monoclonal antibody. Clear? What else? Can we increase the effect of prostacyclin? Yes. What drug we can use?
Epoprostenol.
Epoprostenol. It will increase the effect of prostacyclin.
Ethoxylate.
And what about inhibitors of phosphodiesterase? Can we use this?
Lipidemol.
Lipidemol.
And pentoxifilin, if you, I think that you have pentoxifilin also in the methodical information. Do you have questions about antiagregants? No. They all may lead to bleeding, yes? And if you speak about aspirin, it may lead to what? Ulceration, yes, exactly. Good. It is antiagregants, but sometimes we need to stop bleeding, yes? And we need to increase something, aggregation, something to increase aggregation, yes? What we can use? We say that to activate platelet, we need calcium. Can we use calcium solution? Calcium gluconate, calcium chloride? Yes. We say that to stop bleeding, we need vasospasm. Yes? Can we use drugs which can lead to vasospasm? What drugs? Not. Terlipressin. Terlipressin, it is the analog of vasopressin. You have this information in your classification. Open the first page, please. Look, proaggregants. Terlipressin, solutions of calcium chloride and calcium gluconate. See? You have this information? Yes. And ethoxylate. Ethoxylate will increase the amount of platelets and increase the aggregation. Clear? The second phase of hemostasis is
Coagulation.
coagulation. You know that we have how many ways?
Two.
First activate 12, 11, then
9, 10,
and 10, and
prothrombin to thrombin, to fibrin.
and the second
7,
and then 10.
10.
Who made 10 and the second? Yes? Do you agree?
Yes.
They will go, who makes synthesis of these factors?
Liver.
Liver. From what?
Vitamin K.
Vitamin K. It needs
Need
vitamin
vitamin
K
K.
to make synthesis. In our liver, vitamin K, it is water soluble or lipid soluble?
Lipid soluble.
Lipid soluble. And it can accumulate in the liver in two forms, hydroquinone and
Epoxy.
epoxy. And some enzymes will transform. Yes? If we speak about epoxy, it transforms to hydroquinone. Who transform? Reductase. And hydroquinone by carboxylase make epoxy. But carboxylase is its own activated when it makes from hydroquinone epoxy and goes to make synthesis of factors of coagulation. Yes?
279.
Yes? So to make synthesis of these factors, we need vitamin K. Yeah. If we speak about anticoagulants, they are divided into two main groups.
Direct and
If we speak about direct, they will affect only on
Protein
activated factors. And the main what we need to inhibit it is N and
thrombin.
thrombin. Direct factors, direct anticoagulants divided into two main groups. Yes, which we can use parenterally or orally. If we speak about parenteral drugs, they need something to help them to bind with them and the second factor. What they need? Antithrombin, yes. Antithrombin, the main idea to bind with the second factor, yes? Antithrombin, it is to thrombin. But we have 10 factor, and this 10 factor is very small. And antithrombin C can bind with, first of all, 10 factor. And then it can bind with the second. But to stabilize this structure, we use heparin. Heparin have sugar part, yes, and the tail. If it has long tail, we say about high molecular heparins, yes? And high molecular heparins can bind with 10 and second factor and stabilize the structure with second factor. But if we speak about low molecular heparins, they don't have large tail and can bind with 10 factor and sometimes with the second factor. And if we speak about fondaparinux, this drug also, it is not heparin, but it can bind with antithrombin 3 and bind with 10 factor. It does not have tail, only sugar part. Clear? So, drugs, anticoagulants for parenteral using, heparins, high molecular, low molecular, name the drugs. Low molecular, enoxaparin, dalteparin, fraxiparin. They have parin like heparin, yes, in the word. And fondaparinux also can be used, it is not heparin, can be used to bind with 10 factor. Yeah. Then we have some drugs to bind with 10 and the second factor, which we can use orally. How will be 2 in your language? 2. In your language. 2. Do? How? 2. In your Dua. Not in English, in your language. Not in So deca. So the clone is D, yes? So dabigatran is to second factor. Yes? D at the beginning, dabigatran. And 10, it is very large, no, not name, not letter, but it is, what is not letter? Symbol, the symbol, large symbol. 2 is a small symbol, yes? 10 it is large. River, it is very large. So river of Saba, it is for 10 I remember that. I don't know how you will remember. So to second factor, it will be dabigatran. To 10, rivaroxaban. Is it clear?
Yes.
Clear. Then we say that to make synthesis of these factors, we need what? Vitamin K. Hydroquinone. If we will inhibit this enzyme, we will not have hydroquinone and we will not have activated carboxylase. What drug will inhibit? Warfarin. It is not indirect, yes, indirect drug which will inhibit reductase. We will not have hydroquinone and we will not have activated carboxylase and we will not have factors. How do you think? If we speak about warfarin, it will affect very rapidly or we need the time? Why? Because in blood we have factors and we need to the time to prevent synthesis of these factors. Clear? Usually we give heparin and then during 5 days we increase the dose or the effect of warfarin, then stop using heparin and use warfarin. But if we use warfarin, we need to look at the rate. What rate? International. What the? It might need to be 2 more. Not about 2 and 4. Yes, 4. 2. Usually it is 2. You need only to name international numerous ratio. Yes. Okay. This is the drugs which will make anticoagulant effect, yes? But sometimes we need to stop bleeding and we need coagulation, yes? What we can use? Can we use these factors? Vitamin
Yes.
Vitamin K. Okay, we can use vitamin K. If we will overdose warfarin, I agree. Can we use these factors, first of all? Do you know about hemophilia? When patients don't have any factor, yes, maybe 8, 9 factor, we use these factors to prevent bleeding, yes? Can we use plasma? Yes, it will have a lot of factors. Can we use thrombin, the second factor? Yes, but thrombin we use only topically. We don't give it intravenously or intramuscular. Why? Because it is the main factor, yes? It may lead to thrombosis of all. How we use? We can take some tissue, solution with thrombin, put on the maybe liver when we have a surgical operation, stop bleeding, and then continue the operation. Clear? Also, we have antidote to heparin. Who is antidote?
Protamine sulfate.
So open your copybooks, we will have antidotes and try. Antidote to warfarin.
Take this.
Vitamin K. Vitamin K may be water soluble or lipid soluble. Water soluble minadione and cortisol, and lipid soluble vitaminadione. So, right, antidote warfarin dash vitamin K. If we speak about heparin, antidote will be protamine sulfate.
It is also today
And we forgot about iron, да? If we will overdose iron drugs, we can use what? Deferoxamine. Deferoxamine, it is D without ferro iron, yes? Deferoxamine, it is antidote to iron drugs. Deferoxamine. So 3 antidotes we studied. Deferoxamine. D without deferoxamine. Peroxamine. I think so. Do you have questions about coagulation? About anticoagulants and procoagulants? Do you have questions? No. Next, what we need to discuss is fibrinolysis. Who make fibrinolysis? Fibrinolysin or plasmin. Yes, it is the same. Fibrinolysin or plasmin. It make from what?
Plasminogen.
Plasminogen or profibrinolysin. We need factors of activating, yes, tissue factors of activating to make fibrinolysin or plasmin. It is enzyme? Yes, it is enzyme which make lysis of plasma, yes? So, sometimes when patients have thrombosis, maybe infarction of myocardium, yes, we need to make lysis of this thrombus, yes? And what we can use? Can we use fibrinolysin? Yes. But we don't have fibrinolysin, and we can use what? Streptokinase. How do you think? Do you have streptococcus infection during the year? Yes. If you have a sore throat, it is usual streptococcus infection. So your organism will make a lot of antibodies to this streptococcus. If you will use streptokinase, it may lead to allergic reactions if it is immunoglobulin E, or it may lead to non-effect of streptokinase. Yes? And streptokinase we usually don't use. What we can use else?
Urokinase.
Who make uric acid? kidney. It is not streptococcus, it is human kidney, so it is more useful, yes? What about urokinase? Oh, not urokinase, alteplase.
Tissue plasminogen.
Yes, it will affect only where we have trauma. If we speak about urokinase or streptokinase, they will have effect in all blood circulation. But if we speak about alteplase, it will have effect only where we have thrombosis. Clear? So if your relatives or parents will have infarction of myocardium, what you prefer? Alteplase, yes, because it will lead to less side effects. Clear? How many hours we have to give to make fibrinolysis? How many? As smaller time is better. In our country we have 4 hours to take patient, to put a patient into the hospital and to make fibrinolysis. It is our standard. I don't know about your country, but in our country it is usually 4 hours. We can use 12 hours, but it is not so good. 4 hours, we have 4 hours. But sometimes we need stop bleeding and we need something, I'm sorry, not stop bleeding, we need something to inhibit fibrinolysis, yes? To inhibit fibrinolysis to prevent bleeding, yes? What we can use? Two acids, aminocapronic and tranexamic acid. If we speak about tranexamic acid, it will affect on the plasminogen activating factors, yes, and prevent activation of fibrinolysin. Clear? If we speak about aminocapronic acid, it will affect on plasminogen and plasmin and also prevent aggregation, fibrinolysis, yes. And we say that fibrinolysin, it is enzyme. Can we inhibit enzyme? Use drugs which will inhibit enzymes. Yes. And this drug is aprocinin. We can use, it will inhibit all enzymes. Sometimes we use this drug to treat acute pancreatitis. We will discuss this drug when we will speak about digestive system. Do you have questions? No. That's very good. Do you have questions about your prescriptions?
Yes.
Yes. What drug we call?